So while I'm setting up, let me just say how grateful I am to be a part of this. I think I come from the state of Ohio, where I don't think we have such a statewide push for such an important issue, such an important topic. And so I think if I'm able to provide a fraction of the insights that I've gained over the last 24 hours or so this morning, then hopefully I will have done my job. What I'd really like to do, though, today is to begin to discuss, as a pediatrician, as a member of a healthcare system, how we think about place and how we think about neighborhood in the frame of improving child health, child well-being, and by extension, family health. Here are the objectives I'd like to pull in for the day. First, I'd like to build the case for getting outside of the healthcare system. I'd like to build the case for getting into the community, engaging partners in the community in ongoing efforts to improve health and well-being of our neighbors. I'll then introduce some of the pediatric-focused clinical interventions that we've put into place that specifically address the social determinants of health, these factors that bridge sectors and bring people together in the realm of population health improvement. And I'd also like to identify some opportunities we all have for more proactive intervention, for more proactive improvement, again, that brings sectors together and that brings the family voice into everything that we do. And I'd like to start with this. Here are two pictures. The picture on your left is of the University of Cincinnati Medical Center and Cincinnati Children's Hospital. It's where much of my work takes place, much of the work of my colleagues takes place, inside a large, confusing, intimidating medical center. But much of health, much of well-being takes place out in our neighborhoods. And so I think this kind of push for us to consider the intersection between healthcare and community is one that is particularly powerful. And it really urges us and pushes us to think about what does neighborhood mean for the health and well-being of the populations that we are working with. Many of you have probably seen some of these figures. This is one for Detroit from the Robert Wood Johnson Foundation. So the map may look quite familiar to you, probably far more familiar to you than it does for me. But it's this project that the Robert Wood Johnson Foundation and VCU and some others have put forward to think about life expectancy by neighborhood, by place, overlaying it on maps that are identifiable and understandable for residents of particular cities. So there are a number of these examples for cities across the country. This one is for Detroit, as I mentioned. And not terribly familiar with the geography of Detroit, but what you can see is that as you move from Wayne State University, where the life expectancy in the neighborhood right around there is about 69 years, if you move to the north and to the east, to the Grosse Pointe Shores, you see a life expectancy of 82 years. So gaps of 10, 15 years separated by mere miles, but that are truly worlds apart. And clearly this is for Detroit, but this is true across our country. It's true in Cincinnati, it's true in cities all across the United States. The Robert Wood Johnson Foundation has started to allow each of us to query our own homes, our own neighborhoods, our own settings, and get the lay of the land for us. And some of these websites may be of interest to you. You can type in your zip code, you can type in your city, and you can begin to understand the level of disparity that exists in starting points for something like life expectancy. This has also been put out in the lay press. This was an article from the New York Times a few years ago. They were looking at particular areas within New York City, but the interactive website, again, allows you to do this for your own community. Again, looking at mere miles that separate different communities, understanding the great differences within those communities with a range of underlying conditions, underlying determinants that then lead to profound differences in health measures, namely life expectancy. And this has led many in the healthcare realm, the medical community, the public health community, and across the board to think about those clear intersections between health and geography, prompting this renewed focus that many people say on zip code over or at least in addition to genetic code. Now this of course goes well beyond life expectancy. This is a conference on maternal and child health, maternal and infant health, perinatal health. And I know that from our own work we see these disparities come up over and over again across every measure that we assess. I'm showing a few charts here. I'll start with the big chart to your right. And this is looking at preterm birth rates by neighborhood across Hamilton County, Ohio. This is the county in which Cincinnati is located. So the y-axis here represents that preterm birth rates per 100 birth. And the x-axis, which I clearly don't expect anyone to read, is the 80 or 90 neighborhoods that make up Hamilton County. These are discrete neighborhoods that our community as residents would understand. And what you can see by looking at this is extreme variation as you move from left to right on this figure. There are some communities, some neighborhoods within our city where the preterm birth rate's in excess of 20 per 100, and you look over on the far right where the rate is far lower. And what I will tell you is that the neighborhoods on the far left of this figure tend to be the same that occur on similar figures for a range of health outcomes. I show two others here. The top left is injury rates for children. The bottom left is asthma hospitalization or admission rates. And again, you see huge variation as you scroll left to right. Again, the same neighborhoods that tend to be on the left stay on the left regardless of the outcome we're assessing. I highlight Avondale and Price Hill here because those two neighborhoods will come up over and over again as I talk further today. I'm going to come back to this map, which shows somewhat similar data to what those histograms show. I showed this yesterday, and I wanted to pull it back, again, to illustrate hotspots of morbidity that exist across our county. So this is a map of Hamilton County, Ohio. The city of Cincinnati is essentially the center part of it. Kentucky is to our south. Indiana is to our west, and then some of our more rural counties separate or border us to the north and to the east. What you're looking at here in terms of the spread from a light orange to a red is hotspots of days that children spend time in our hospital across any diagnosis, across any condition. And what you can see is that there are certain areas of heat. Two of those areas of heat, once again, are Avondale and Price Hill. Again, we'll come back to those. But those same areas of heat tend to be areas with high rates of poverty, high rates of racial segregation, high rates of inadequate housing, and limited access to reliable transportation. As we think about what we can do to begin to cool these hotspots, we must think about what is it about neighborhoods like Avondale and Price Hill, what are the risks that characterize them, what are the assets embedded within them that can be leveraged. And I think as we think about this and as I move into some of our additional efforts, what I wanted to truly do is bring in insights from a case. And I'm going to try and show a video. We checked it this morning. I know there were some challenges yesterday. So we're going to try and show this video. It's about 3 minutes. And I think shows the power of place, shows the power of community, and shows the power of the family voice. So with luck, I will introduce Josiah and his mother.
In 2009, I gave birth to my beautiful boy, Josiah.
It was a little loud. I'm going to try and we'll start it again, a little quieter.
Walker. He wasn't a child that you could just, have.
Sorry. We're going to try again. So it's working, but it's just a little loud.
Those children just go home straight.
We're going to do this. Thanks for your patience, everybody. All right. Now I introduce to you Josiah and his family.
In 2009, I gave birth to my beautiful boy, Josiah Walker. He wasn't a child that you could just, how most children just go home straight from the hospital. My son had tubes and everything stuck in his throat, up his nose. Then they finally put the trach in and rushed him to Children's, where he stayed in the NICU for 4.5 months. And in the house, the roach, oh my God, it's like, this whole building is infested with everything, basically. It had roaches, spiders, and bedbugs, because this building is infested with everything. And it's like, I have to sit up all night watching my children to make sure nothing is crawling on them, especially my, especially my 1-year-old, because he has a trait. And I can recall that he had roaches in his bed. It's January 2009. 2010, I was able to bring Josiah home from the NICU, and spring started hitting around, and in the apartment it was very hot, and children's clinic told me that I had to have air conditioning for him, or it was required for him to stay there. So I went to Cincinnati Urban and I told this to them, which they told me no. And then I got the letters from the high-risk clinics explaining to them that he was required to have this in order to breathe. So I took the letters to Cincinnati Urban and they still told me no. I told them that I had my own window units and they told me no still. Cincinnati Urban still refused to accommodate him. So after that, they served me with an eviction notice, saying I had a couple of days or 30 days to get out because my son is required to have air conditioning in order to live. After eviction notice, I went to legal aid, got assistance, and went to court where the judge ruled in his favor, saying that he can't have air conditioning. Now we're blessed with this subsidized apartment. It's very nice, beautiful, and it's safe, clean. We have central air now for my child. My children can go outside and play. We have 2 bathrooms, clean, working, and it's just a safe, lovely environment for me and my children.
So we're going to unpack that video a little bit over the next the next stretch here, but I did just want to summarize and illustrate the power of what we just heard. So here was a child who had been diagnosed for this medically oriented with a Pierre-Robin sequence, who had a NICU stay that measured 4 to 5 months. It was rocky. He had feeding and tracheostomy tubes placed, and they were in place at the time of discharge, adding to a great deal of complexity in which this child was going to be discharged. But when he left the NICU, he was discharged to this building that you see here that was characterized by so many unsafe and unhealthy conditions articulated by his mother. And that one quote hits me every time, that this mother, who was clearly tired, was dealing with other children and dealing with a child with complex medical needs, was sitting up all night watching to make sure nothing was crawling on Josiah because he had a trach. This vivid picture in my mind of a child with a breathing tube lying in his crib with a mom eagle-eyed to make sure that no cockroach crawled into that tube. And if it wasn't bad enough, they were dealing with a very hot spring, we'll come back to that, and an unfair threat of eviction. So it's no wonder that the next several months of Josiah's care were quite rocky as well. This child was in and out of the hospital, in and out of the emergency room, and mom's mental health deteriorated until she began to get help. And it's that help, that's assistance, that collaboration, that kind of partnering that I feel is so powerful and that we're going to talk more about over the course of the next half hour. I'd also like to highlight that his challenges are not necessarily unique. We've done some other qualitative interviews of our families hospitalized on our wards for any other condition, not necessarily conditions that involve tracheostomy tubes and feeding tubes, but issues like asthma, pneumonia, and failure to thrive, and other things like that. And here are some direct quotes from some of our families. One noted that my window is broken. There are roaches. My landlord isn't responsive to my concerns, similar to what we heard from Josiah. Another noted that it takes 4 hours to get to the pharmacy, 2 hours to get there walking, 2 hours to get back. I just can't do it. So again, we may prescribe medicines. That doesn't necessarily mean it's easy for those medications to be received. Another noted that I don't have transportation. I had to catch the bus everywhere. It was really, really hot the next day. And by him having a breathing problem, I was scared to catch the bus. Again, this idea that we take so many things for granted when we provide instructions at the point of discharge. And this last one, which I'm always particularly struck by, is a mother noted that I was in the hospital with no money, with no one, no food, no gas. And it was just horrible because I was breastfeeding. This is another child. And I'm basically eating nothing but cereal or a little scrap that she, the patient, doesn't eat so that I could sneak it in before the doctors come and see. So again, the reality faced by many of our families And so it really should push us to think about what are the supports that we have in place, how are we developing our care practices to align with that which families need and want. And so it's this idea of place, this idea of context, really working through the so-called social determinants of health. And I provided this definition to a group yesterday. I'll provide it again. This is the definition for the social determinants from the World Health Organization, highlighting the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. So it's both this idea of context, but it's also the systems that create that context. Much of what we heard from Dr. Gray yesterday, this idea that it's not just one exposure or another, it's what's been baked into the system. And just to think about this pictorially, here's another picture of that same building. That's Josiah's building on the top. A few miles away is the Hyde Park neighborhood. It's one of our more affluent neighborhoods within the city of Cincinnati. You see a bustling farmer's market, which is a lot different than police cars and fire engines. Now, many have begun to illustrate the relevance of the social determinants to healthcare provision and to medical outcomes. And I think we've come to understand that medical care alone is insufficient to truly achieve the outcomes we desire. There's also essentially this understanding that one may often see the statistic that 80% of health outcomes are determined by non-medical factors. I think there's some truth to this, but I think one thing I'd like to highlight from this often cited figure from the Robert Wood Johnson Foundation is that even what they consider to be clinical care in some capacity could be thought of as social and contextual determinants. So if you look at this, and you look at the top there, the health outcomes we're trying to achieve, one could argue are both length of life and clearly, importantly, or quality of life as well. And embedded within that are those health factors that relate to health behaviors, clinical care, I'm going to come back to that, social and economic factors, and the physical environment. So clearly, some of the relevance of health behaviors, socioeconomic factors, and the physical environment can be thought of as social determinants. But if you look at what we include here, or what they have included here in clinical care, it's access to care and quality of care. Now, access to care in and of itself probably is embedded in contextual factors as well. But even quality of care, I think much of what we heard yesterday about implicit bias and about the differences in care that we heard from Ms. Irving in the afternoon still highlight the importance of context even in the realm of the care that's being delivered at the bedside. And I think this intersection of health and place is really pushing us to overlay relevant information so that we can make best decisions possible with our patients, with our families, with our communities that often identify other key partners in action, those who are more capable, more able, have more expertise in addressing those non-clinical factors that so certainly influence health. And so one of the things that we've been really interested in Cincinnati, and I think it's becoming more of a place of interest across the country, is this intersection between health and place. And Francis Collins is the NIH director. Even he is beginning to think about this in the overlay of, say, DNA and what he calls ZNA, or this zip code, as a key determinant of our health and well-being. And though I don't agree with everything he says in his tweet, I think this mere concept that it's being elevated in the realm of biomedical science is probably a move in the right direction. And we've started to think of this term geomarkers as a means through which we may better understand the life of so many of our patients and populations, these geographic measures that help us to think about the potential for incidence or outcome of disease. And here's a version of what I mean by that. Again, overlaying key elements that begin to get us at information that will begin to characterize the communities that surround us. So here are 5 maps of Cincinnati. The top map includes all asthma-related emergency department visits and hospitalizations. And you can begin to see the distribution of those. And then underlying that are certain data elements that we've either extracted from public city records or from the US Census, beginning to think about what's the crime rate in certain neighborhoods, what's the poverty rate in certain neighborhoods, how does housing quality influence health and well-being, and what does access look like if there are limited healthcare resources within certain communities. And another way to think about this is where is the morbidity, where is the risk, and where are the resources? And this is something that's really pushed us to think about interventions that are potentially capable of meeting the needs of our families. And so I'm going to show two maps. I'll put them both up here. The background on both are asthma admission rates measured per 1,000 children. The red areas are the so-called hot spots. Green are the cooler spots. And the blue dots represent, in the top left, asthma admissions. In the bottom right, they represent legal aid housing cases, much like what you heard on Josiah's video. And we've circled a couple places here that, to us, we didn't do any statistical analysis here. We just circled a few areas that look to be clusters of blue dots in both figures. And I will highlight that this area, this blue circle, is where Josiah lived. But it's this kind of toggling back and forth between sectors, between worlds, that sometimes provides us with important instructive answers. And so here we saw this intersection between asthma and housing. As I mentioned before, so much morbidity follows this same path that we're beginning to see this overlay as potentially powerful beyond. And in fact, when we began with a set of maps like this, it really pushed our partnership with legal aid further still, beginning to understand that we were really working with and for the same populations. Now, how do you get there? How do you get to intervention? The first place, of course, is asking the right question and understanding the context in which our patients and our populations live, work, grow, and age. And the National Academy of Medicine now recommends routine and standardized collection for a range of topics that include race, ethnicity, tobacco, alcohol, and residential address, in addition to other key factors that get us a little bit further to understanding the day-to-day life. So what's the educational attainment of the patient or the parent? What's financial strain? What's stress look like? What's mental health look like for that particular family? And in fact, they went on to say, what does the neighborhood median household income, to begin to think about what the neighborhood context might be for that particular patient, population, or family. And I think they've also pushed us to think about how to best integrate these data into our health records so that we can see them as key elements of the care that we're providing. And in fact, the organization that I belong to, the American Academy of Pediatrics, now encourages screening to, quote, facilitate prevention services and improve the health of all children. And I embolden to all because this truly should be our goal. This should truly be the place within population health where we're striving to get to. Now, I want to walk through how we do this in our center, how we've connected it to action, and ultimately how it's led us toward population health improvement. So this is a current iteration of our social history screener that we provide every patient that walks through our door in primary care. Generally, it's filled out in the waiting room either on paper or on a tablet that is then entered into the electronic health record. The provider team reviews and determines with the family what the appropriate intervention could be. Sometimes it's just tailored anticipatory guidance. Sometimes it's referrals internally to our social work partners or our behavioral medicine strategists. Sometimes it's external referrals to legal aid or to other organizations, as I'll talk more about in a moment. Now, there are many models for this nationally. We're exploring place-based data. It's not currently a piece of this, but this is how we currently do it. And I'd like to underscore the point that screening, in my view, is a start. It's not an end. It's a start of a conversation. And it's a start of a way to think about how we may work together to achieve the outcomes we so desire. And so as an example, let me start with the top two questions on this screener. They deal with housing-related issues. One is, are you under threat of eviction for reasons other than not paying rent? And are you currently having any problems, roaches, rodents, mold, et cetera, that your landlord is not helping you with? And this takes me back to that video of Josiah because it was so critical in terms of how we began our efforts into thinking about what might be a good strategy to work with this family to begin to respond to these needs. And as part of this, we've begun to think about what a table might look like as we think about, say, a health service environment. What's your access look like? The physical environment, housing, the economic environment, resource availability, and that psychosocial environment, that safety consideration to help us think about how we can move toward intervention. And I won't go through each of these, but this has begun to be, this was an early matrix we put forward to think about how to, again, match need with resource in the pursuit of equity. And we're going to talk more about legal advocacy, again, in the context of Josiah. But before I get there, I also want to highlight one of the ways in which we have moved from identifying a need to identifying an action step and indeed a partner. Now, I imagine just about everybody in this room has seen a version of Maslow's hierarchy of needs. It's kind of necessary. It's necessary to see it as you pursue any line of this work. And I think just as a review, those kind of basic physiologic needs are at the bottom. But what we're really trying to do is ascend that pyramid, ascend that hierarchy, so that we can support the achievement of one's true potential. And as we think about this, we've begun to map, say, risks and assets to each of these levels. You can think about housing conditions, food availability at the bottom, and you can work your way up towards employment and education, again, trying to support individuals as they move towards their full potential. But we've also tried to think about how these risks and how these elements, these lines of Maslow's then map to potential academic or clinical community partnerships. So what are the key agencies, organizations, groups within our own community that are actively working on these issues? Again, we as physicians, we as the healthcare system may not be the experts on this. In fact, I would suggest that we are not the experts on this, but we have this convening power, we have this relationship, we have this trust that can often be connected to those community agencies who are. So let me highlight this one, because I think this is, of all our clinical community partnerships, this is the one that's been taken the furthest, and it was really brought out in that video with Josiah. So Child Help is our medical legal partnership, and this is a partnership, a true partnership between Cincinnati Children's Hospital, particularly our primary care centers, and the Legal Aid Society of Greater Cincinnati. It includes on-site attorneys and paralegals that work with us generally 5 days each week, in clinic, able to see patients and families in real time. And they're very adept at handling issues like housing concerns raised by the video, public benefit denials and delays, education services, and other kind of family law issues as well. And they also have deep connections with city and county agencies to support further connections outside their realm too. Because we're a teaching facility, because we have a lot of medical students, residents, and trainees, they've also been critical to our interdisciplinary advocacy training. So they give some of the lectures to our students, to our residents, about what it means to have public benefits, what it means to have certain rights with respect to housing. And since 2008, since the onset of this partnership, we've seen more than 6,000 referrals with evidence for reduced risks related to the social determinants. We've seen early evidence, which we're analyzing now, about its effect on both utilization outcomes, like hospitalizations and days children spend in the hospital, but also preventive care completion. And it's also been a very effective tool for moving from patient to population, for pattern recognition. So what do I mean by that? In the video, you heard Josiah's mother talk about a very hot late spring, early summer. And one of her concerns, one of her complaints, was that she was trying to put in a window air conditioning unit during this very hot season, but was told that she wasn't able to do it by her landlord. And in fact, the screenshot on the right, I added the box, but that's a PDF letter that, I don't know if this one came from Josiah's family, but what I will tell you is that we got 16 referrals of very similar complaints during this hot summer. And they all, or most of them had these air conditioning complaints. Most also were talking about pests and mold, much as you heard in the video. And when we looked at the data a little bit later, we saw that the kids living within this particular set of buildings had high rates of asthma, high rates of developmental delays, high rates of lead toxicity, high rates of medical need. But what we were able to find, again, by looking at all 16 referrals that came in internally as the medical staff, but in partnership with our legal aid partners, was that each of these referrals was coming from the same set of buildings with the same common landlord, the Cincy Urban that you see up there. 19 total buildings, 670 subsidized units. The properties were amass in violations of city ordinances, and they were moving towards foreclosure. But what we were able to do by moving from patient to population health was to support legal aid as they worked with tenants to form a tenant association so that there could be collective advocacy, not one by one. So in essence, this pattern recognition through collaboration took us from one patient or one family to 16 households and ultimately to tenants of these 670 units. And so here's kind of a before picture. You see, this is one of the buildings of the community. The Josiah's building, which I showed earlier, is a second. And this is the kind of front lawn of the building. It's hard to tell, but it's certainly been poorly kept. You see some pictures from inside, holes in the walls, falling in ceilings. And then a few months later, after the tenant association was formed, after legal aid began their advocacy, we saw systemic repairs that included improvements on the inside of these buildings, but also new roofs to try and get more at systemic concerns. And happily, the story continued. Soon after this set of buildings went into foreclosure, they went under new management. The Avondale neighborhood, which is where these buildings are based, with local development corporations supported by Cincinnati Children's and others across the city, got a large HUD grant to allow for major repairs and renovations, not just new roofs, across 5 of the largest complexes, including the one that Josiah lived in. The subsequent Build Health grant, which is what is currently in process, builds in health champions. So these are neighbors helping neighbors, being kind of the core node of a social network within these buildings to begin to elevate concerns more rapidly. And together, all of these efforts have led not just to the positive outcomes that we saw in the Josiah video, but also evidence of positive health, education, and safety outcomes across the board. Again, just to toggle back and forth, here's a before, here's an after, before and after. And the improvement certainly it goes further into the indoors of this building and the other large complexes now managed by this group called the Community Builders. Now, national medical legal partnerships are not unique to Cincinnati. We're very proud of ours, but there are 300 medical legal partnerships across 46 states. I looked it up, there are 7 in Michigan. And they generally involve, they can all look different, but they generally involve legal aid agencies or law schools that have partnered with a range of health providers. They could be hospitals, they could be healthcare systems, they could be clinics, but in essence, they're there to meet the legal needs of populations that so often don't have their legal needs addressed. I'd like to walk through one other example. Housing instability, housing insecurity is a key area that we've worked. Another is food insecurity. And this is really referring to the limitations on the availability or accessibility of nutrition for a given household. We did some needs assessment in our own clinics several years ago and found that we had high rates of food insecurity. We had high rates of formula stretching among formula-fed babies, which puts babies at a host of risks for so many things. And we also had challenges accessing nutrition within the neighborhoods so many of our families and patients live within. And you can see as a result, we now add 2 food insecurity questions to everybody that comes through our doors. And we've started to think more about how food access challenges can be addressed relating to transportation, availability, convenience. And I like this figure because one of the design students in Cincinnati did it for us in thinking about the equity gaps or inequities of food availability. And so just as an example, in the top panel, you can see someone driving their own car, able to put their groceries in the back seat and safely move between their house and the store. Another might have to do it on a bus, which makes it more challenging. Several of our families walk, and they're walking with their other children, which not only limits the amount that they can get, but it limits the potential availability of healthy nutrition that you can see on the bottom, given what is accessible within their own community. And so I showed this picture yesterday. I just keep coming back to it. This is, again, the produce section that existed in one of the corner stores in the Avondale neighborhood, the only place to get produce within that neighborhood. So early on, we saw this as a need. The Free Store Food Bank, which is the large local food bank in our region, had limited access to infants and young babies who were in food insecure households. So it was this natural partnership that was developed. And we implemented this program aiming to minimize food insecurity within these households, bridge to additional resources that were within the community that the Free Store Food Bank was well aligned with, and also, as with legal aid, to enhance the teaching of social determinants within our primary care setting, remembering that we have a number of trainees that move through our clinic every day. And since that time, this has been largely focused on, again, infants to date. We've distributed 5,000 or more cans of formula. We've also made innumerable connections to our breastfeeding resources for those families that are breastfeeding. And we've seen early evidence that families who have been engaged with this program are more likely to receive subsequent preventive services. And our hypothesis, our theory is that by addressing needs, even if we can't solve all problems, but by addressing needs and being a trusted partner in addressing needs, we see our families as being more likely to keep coming back to us. The spread plan, though, is of course important. We've engaged with other clinics across the region. We've bolstered education, and it's even led to a very recent, just in the last year or two, placement of on-site food pantries to bolster our services for those families that don't just have infants but have older children as well. So we now have food pantries at 2 of our largest clinic sites. Again, this is not meant to solve everything. It's meant to be a bridge, and we now provide 3 days of shelf-stable food to the households we identify as being within need, having that need. Since 2017, this is more than 15,000 pounds of food that's been distributed across now probably 300 families. It's helped us identify siblings that have been, quote unquote, lost to follow-up who need additional care services. It's also facilitated countless, probably close to 300 now, connections to our social services department, legal aid, and other community resources. And happily, the second pantry just opened about 2 months ago, and it's going quite well. And again, patient stories are incredibly important. Here are some of the qualitative feedback we've received to date. One noted that it was a blessing. This was the first time I really had no food and you had food. And the food held us over until my food stamps came 1 week later. It's the right amount at the right time. And then I was able to focus on other necessities like clothing and diapers. And then finally, it opened the door. I now feel more comfortable asking for help if I find myself in a situation where I need assistance. I know you all will do your best to help my family. Again, this desire to be there for whatever a family might need, whether it be medical or something that influences health but may be contextual. And as we think about a broader spread plan, we've begun to think about how place might help us do this. And so this is a map of all the counties within southeastern Indiana, northern Kentucky, and southwestern Ohio that are served by this one particular food bank. The background rates in orange and red represent food insecurity rates. And then we started to put dots on here about food pantries that the food bank networks with, as well as primary care providers across our primary service area. And you can begin to see that, relative proximity and the potential for potential partnership between these 2 critical agencies. Now, as with legal aid, there are food banks, there are food pantries that exist all across our country. Feeding America is a wonderful repository of information that can be queried by zip code or state. This map that I pulled up here identified the Greater Lansing Food Bank as what's the one that serves this particular community. Again, the beginning of opening the door for partnership. Of course, there are other models for Action 2. Health Leads, some of you may have heard of, is kind of a help desk type model, generally staffed by college students, to begin to help patients and families connect to resources that might exist within their community. Street Cred is a wonderful organization that is particularly timely this time of year. It's to help families, households do their tax returns and sign families who are eligible up for earned income tax credit and other public benefits that help potentially widen the pie of where resources might be directed. I think I've met some community health workers here. I know community navigation, community health work is critical. Again, extending the reach into the community, and often thinking about other parts of the community as hubs to where efforts can be pursued even more readily, such as school-based health centers. And of course, policy gets at some of those systematic issues, those system issues that I think are so important at the core of why disparities exist and what need to be remedied for us to make lasting change. I think I was particularly gratified that your governor was here. I think to understand the political landscape of both a state or a locality, I think is really important to think about how we might reach toward equity. We can do a lot within clinical settings or within communities, but ultimately we need that system level change. So in my last little bit, I do want to get through some insights we've learned and some work we've done through our Cincinnati Children's Population Health Initiative. And I'll show one more of these charts. This one is looking at all-cause inpatient bed days, again, across all conditions. I don't care whether it's asthma, pneumonia, UTI, surgery, across all conditions. And what we've done is tabulate this by dividing the number of days children from a particular community spend within the hospital divided by the number of children living within that community. And once again, you see this extreme variation, and you see Avondale, which is our own backyard, coming in at number 4. And once again, that's Josiah's neighborhood. Let's think of it a slightly different way. So you can categorize these neighborhoods based on underlying rates of child poverty. So we did it by quintile, so about 20% of the population in one of 4 categorizations, from low poverty to high poverty. And what you can see here is that as you walk, the formatting, I'm going to not use that because the formatting got messed up, but as you walk from the low poverty quintile to the high poverty quintile, there is a stepwise increase in the bed day rate for kids within those neighborhoods. And just to tabulate this a little further, that if each neighborhood, if each census tract had the same inpatient bed day rate as the lowest poverty tracts, the 20% of tracts or neighborhoods that had the lowest rates, there would be 33% fewer bed days each year. 8,000 fewer days that children from Hamilton County would be spending in the hospital. That's 22 child years altogether where kids would be spending in their home, at school, parents at work, parents in their home communities. So great opportunities for improvement, and great opportunities for improvement that exist across diagnoses and across specialties. So we began to look at the disparities between high poverty and low poverty neighborhood across conditions. We've put this on a normalized scale so that each condition had, this was what it would look like if each condition had the same number of bed days. And the red represents the high poverty neighborhood, the blue represents the low poverty neighborhood, and you can see for respiratory infections, injury, asthma, epilepsy, every condition on this chart that the red bar is above the county average and the blue bar is below the county average. I work in a large healthcare system with countless subspecialties, and we did the same exercise for kids on the services of our various subspecialties. And you can see, once again, that for every subspecialty at our hospital, with the exception of bone marrow transplant and neurosurgery, the red bar was above, the blue bar was below. Again, illustrating that disparities are not just in primary care, disparities are not just in the NICU, disparities are not just on the general wards, they're across the board. They also extend to pharmacies. So this is data we got from Kroger Pharmacy across our region. We only were able to do this by zip code, so it's a little bit less granular, but we were able to look at low poverty zip codes compared to high poverty zip codes and the rate at which prescriptions were not filled within 30 days. So here the lower is what you want to be, and frankly the rate across the board is probably too high, it's probably high, but you can see that there's this stepwise there's this stepwise relationship across the poverty level of the various zip codes. And this extends to medicines that I would think are pretty critical, including anti-epileptics, diabetes medicines, mental health medicines, every single class that we studied. So where do we go from here? This is ultimately important data, of course, but ultimately we want to narrow these gaps and improve outcomes. And I would suggest we need to do so by getting to shared root causes, understanding our community's needs, addressing those needs with them, and harnessing our professional responsibility toward action. And so this is Cincinnati's strategic plan. This was new as of 2014, 2015, looking forward to 2020 and beyond, that we would help Cincinnati's 66,000 children be the healthiest in the nation through strong community partnerships. So we had this desire to improve care or improve outcomes for all, and to do so with partners. And we have 4 main goals. One is to eliminate infant mortality. The second is to ensure that all 5-year-olds have a healthy mind and body, and part of the initial goal was to define what that actually meant. A third, done in partnership with Cincinnati Public Schools, was to support children and ensure that they were able to read proficiently by 3rd grade. And the fourth, which is the one where I spend most of my time, is to think about how to reduce disparities in hospital admissions and hospital bed days across neighborhoods. So let me just briefly talk about that. We set a goal back in 2015 that, starting with Avondale and Price Hill — Avondale is Josiah's neighborhood, Price Hill is a similar neighborhood on the west side of Cincinnati — that we would reduce the inpatient bed day rate for those neighborhoods by 10% by 2020. And we sought to do this knowing that there were plenty of risks within this population, within these neighborhoods, but plenty of assets too that were already engaged and at the table with us. These were schools, school-based health centers, there were primary care centers, there were social service agencies, there were pharmacies, all who were aligned with this goal. And I should underscore that with us were also families from these neighborhoods. And so here are just a brief array of strategies we've used. Again, thinking about this along this realm of what can we do with a particular child or family, what can we do as a health system to improve the care that we deliver and the equity in the care that we deliver, and then more broadly as a community and as a society. And so we always put the family at the center of our care. We try and think about how we can work with them to achieve their goals. We always think about how we can learn from each hospitalization what we can consider a quote-unquote failure, how we can co-design solutions with the end user, developed with trust and community input, and ultimately how we could recognize those patterns like what I illustrated with the buildings before. So let me start with this. We've tried to make it as easy as possible to have our children receive the right treatment at the right time in the right place. Sometimes this means thinking about how we can deliver the medication to them. Sometimes it means altering the anticipatory guidance we provide to align with their home context. Of course, this also requires building relationships with families and community partners that are central to the care that we're trying to get. And it also involves thinking about how we might risk stratify so that we can align some of the rarer resources that we have at our disposal. I mentioned daily learning from each hospitalization. Every morning at 7:30, my team gets an email automated from our electronic health record that tells us if any children were admitted from our target neighborhoods. There were 3 this morning. I got it earlier today. What this prompts is a morning huddle, multidisciplinary huddle, composed generally of physicians or nurse practitioners, social workers, community health workers, community engagement consultants, and school services. We're trying to figure out how to get the family perspective here. It's currently been a little bit challenging with privacy issues. But what we try and get at is those root causes that might have been in place that could have prevented this admission in the first place. We look at preventive care gaps like immunizations, lead screening, developmental screening, which might be able to put in place prior to discharge. And then we try and think about what transition needs we might be able to offer the family prior to them going home. As we move up a level, again, we've tried to really push towards co-design of solutions. I'll highlight 3 examples of this that have been built over the last number of years. The first group calls themselves the Reading Bears and Caring Families Group, and it's a group of mothers and grandmothers within Avondale who meet weekly and really push parent-to-parent coaching to increase healthy behaviors. And they started by being interested in reading at home, but have since kind of moved well beyond that to think about other potential areas in which they could partner with their neighbors. And this picture at the bottom is a picture of a recent meeting of that group. Out of that group came justice promoters. Again, many of the mothers and fathers now from the community are now aligned around thinking about what one's legal rights are. And so they're developing information that they can pass out to their neighbors, that they consult with their neighbors about renter-landlord interactions, such that perhaps the situation with Josiah could have been remedied more quickly. And then finally, the Healthy Homes Block by Block initiative is in Price Hill, not Avondale, but it's neighbors connecting with neighbors to deliver books and safety supplies and provide education to families about engaging in care practices that might be necessary. And I will mention that this program began as a handful of block captains, as they called themselves, neighborhood mothers, who would literally walk a block, knock on doors, and try and find women who were pregnant or were contemplating pregnancy and get them into prenatal care. We've also worked with our community to think about how to recognize patterns more readily. So this is a laminated map in the basement of one of the Avondale churches that we spend a lot of our time. The push pins are individuals that they've engaged with, and we've tried to move from that to a series of other maps that we can create electronically, share with our families, share with our patients, to think about how they experience health and well-being and how they experience those factors that affect their health and well-being. And finally, the concept of academic or clinical community partnerships being phased and tactical, ensuring that we're working together along a continuum that ensures that we're always thinking about the future, that we're always measuring our outcomes, and that we're always revisiting what our mission is. And here are some of our results. So I told you our work began in 2015. We track our work on a statistical process control chart, which is a fancy way of looking at data over time. Here, the y-axis is the inpatient bed day rate for Avondale and Price Hill, normalized by population measured per month. The x-axis is time measured in months, so each blue dot represents a month. And there are rules that tell us when we're able to, say, shift that red line, which is the mean, down. And we were able to do so after we initiated our efforts back in the summer of 2015, such that there's been an 18 to 20% reduction in the bed day rate for Avondale and Price Hill. And to make us think that what we're doing is truly making the difference we want it to, we've seen no background change in comparison to neighborhoods with similar morbidity profiles, neighborhoods we hope to spread to in the near term. So I want to close with a few parting thoughts. Again, thinking about how we can work with activated neighborhoods for population health improvement. Here are a couple pictures from some of our groups. The top one advocating for school-based improvements. The bottom one is another picture from the Reading Bears Caring Families group. And I think the starting point is to think about why. Why are we doing this? What is our story? Why do we get up in the morning? What keeps us up at night? The what, the how are a little bit easier to think about, but what is the why? What is the reason for this work? And for us, it's places like Avondale, the vibrancy of those places. It's patients like Josiah and his family with dealt a bad hand that we can potentially work with and support. And I think on this front, I was particularly struck not just by the presentation of Ms. Irving yesterday, but this quote. So if you have come here to help, I wrote it down, if you've come here to help me, you are wasting your time, but if you have come because your liberation is based up with mine, or bound up with mine, then let's work together. And I think this is a component of our story. It's working with neighborhoods like Avondale and patients like Josiah to find our collective liberation. And I believe it's our special obligation to do so. Many of us took an oath with those words directly embedded, that we have this responsibility to support the well-being of our patients. We have this responsibility to prevent ill health among populations. And I think there's the urgency for us to determine the best models to improve health and reduce disparities that push us outside of our walls. So what will it take? I think based on what I've seen here over the last 24 hours and what I've learned over the last several years is that we truly must address structural impediments to equity. Poverty, racism, discrimination were not created overnight, but we must strive to uproot them and remove them from the equation, because currently that's what's driving so many of our ill health outcomes. I'd also suggest that organizations across sectors will move us toward those solutions more quickly, and they will move us toward common missions that we all might have, but we all may not know we have. But nothing will be successful, again, in my view, without being responsive to the voice of that community, being collective liberators with them. And so lastly, I would suggest that we need healthy environments in which to grow, work, live, and age. Again, meeting the needs of the social determinants of health by matching need with resource and having this eye of equity at every turn. And we should also have high expectations for what should be possible. We should not have the disparities we have. And until we begin to mitigate them, we should continue to work. We should continue to be collective liberators. So I'll close there, and I'd welcome any comments or questions. Yeah, so we were able to get formula supplies from businesses. So Kroger, Costco, others have been either donating them, or our food bank is able to purchase them at low cost. One of the key things that we've done as part of that initiative is particularly to focus on getting formula that's generic and not brand name. And as I'm sure is the case here in Michigan, our WIC only provides brand name formula, but if you're buying out of pocket, that's far more expensive with no real increased nutritional value than generic. And so we've tried to kind of tried to bridge both, but we did not work through WIC specifically to get that supply.
First of all, I think this was just a great presentation. I have all kinds of ideas in my head right now. What I heard you talk a lot about was the health system and the community partners. I'm wondering where the role of any of the Medicaid health plans in Ohio. I used to live and work down there for a couple of years, so just wondering how that collaboration or support, if it was there.
Yeah, so the question, if you couldn't hear on this side of the room, related to health plans and payers, particularly Medicaid. And I think it's a great question. In Cincinnati, which is different than other parts of Ohio, we're still largely a fee-for-service model. And so I think part of the push for us to do this was a mission-directed push, return on mission, but also with forethought that eventually we're going to be more on the value side. And so it behooves us to think about that economically. Currently, Ohio Medicaid has been supportive, but not directly supportive. I mentioned some early analyses we're doing around our legal aid outcomes. We're partnering with Ohio Medicaid to do some of those analyses, but we currently don't have incentive models for this in Greater Cincinnati. I think that's critical, and I think actually we would move much more quicker if our incentives aligned. And in fact, in Columbus and Central Ohio, they have a large accountable care organization for kids that covers 300,000+ patients. We don't have that, but it's led to some changes in the way that they've structured their innovation, which is different than what we've done.
In the apartment complex in Avondale, when those changes were made, can you tell if the rent stayed the same or if there was an increase?
So the question was about the changes within those apartments and whether rent stayed the same, and it did, and that was part of what went into that HUD grant, was that anyone who lived within those apartments would have the option of staying within those apartments at a subsidized same rent after the improvements. That was part of what went in to that particular agreement. Yeah, so I know we're about at time, but let me briefly answer that because I think it's important. I think the two things that really help accelerate this is one, analytics support, and 2, capacity building support. And so I kind of glossed over it for time, but we have what's called the All Children Thrive Learning Network, which is a collaborative that was kind of bolstered by Cincinnati Children's, but it brings together, we have now 150 or so families. We also have a range of social service agencies, schools, and other people that come together periodically that are arranged around these common goals, these common missions. And part of that has been direct capacity building. So we're a quality improvement site, so those are the methods we often use. But we've taught, we have a series of courses that directly teach people at the front lines, whether you're a family or a frontline care provider, writ large, that teach how to think about implementation and tracking those outcomes, and we provide supports to begin to think about how to measure that over time. And we have levels of that push all the way up to the C-suite of Cincinnati Public Schools, our local welfare office, and others to try and align around these common tools, common measurement strategies, and common intervention strategies. And then the last thing I'll say is that a lot of this has been rooted around this concept of co-design. So we've integrated community organizers and design experts to help us think through how to actually implement those types of things that bring that voice that's so central to what we do into the conversation. That's short. If you're interested, I'm happy to connect further about what All Children Thrive does.
Could you repeat the whole name, All Children Thrive?
So if you were to Google, and I'll get the right webpage for you, but there are 2 All Children Thrive organizations that if you Google, you'll find. One is a nationwide network that brings together multiple cities like ours that are doing this type of work. There's All Children Thrive Cincy, or Cincinnati, I think it's ACT, I'll find it for you, that is specific to our organization.
Are any of your technical colleagues doing
Yes, thank you. I meant to mention this. Yes, thank you. So the infant mortality objective directly brings in obstetrical leads from our 2 largest birthing centers. So yes, they're clearly squarely at the table for that particular goal. The other thing I wanted to mention, which I meant to mention, is that, so I talked about Child Help, which is our medical legal partnership. Recently we started M-Help, which is spreading aspects of that legal aid partnership to one of our largest perinatal clinic with obstetricians at one of our birthing hospitals. So we're trying to move up into that realm so that we can align across the perinatal space, obstetrics to pediatrics. Oh, yes.
You talked about a lot of the medical conditions that have been addressed. What about mental health, and how is trauma-informed care integrated into all of this?
Yeah, so another great question. Trauma-informed care is another place where we're spending a lot of our time. In a partnered, I'll call it a learning network, I'm not sure that's the right thing to call it, called Joining Forces for Children, is also being pursued in Cincinnati under the leadership of some of our colleagues in psychology, schools, and some of our more mental health specific programs. They're focused on trauma-informed care within the schools, within our clinics, and also focused on how we might build childhood resilience in more meaningful ways. So it's a key element there. Most of that work takes place through the organization called Joining Forces for Children. Yes, ma'am.
Just a really easy question. How would you even start doing this?
I know that's another hour.
Yeah. So I think the starting point is to align on a mission, align on a goal, and I think to do so collaboratively is probably key. So once you have the mission, I think then it follows to say who needs to be at the table. And I think it's okay to start small. It's okay to start in one practice, in one block of a neighborhood. But I think starting with the clear goal in mind is key, and then ensure that key voices are represented. I think those are probably the most valuable starting points, but it can get complex fast, and I think it's okay to start small while you retain that eye for spread. It's a long conversation. And we're at time. But thank you, everybody.